Okay. Good morning.
Good morning, sir.
Today we will have a journal presentation. There are supposed to be two presentations, but the second presenter is not present. So the first presentation will the loan presentation will be a comparative study of lab processing with low pressure and standard pressure neoperitoneum. Dr. Abhishek Tiwari, who is the first year junior resident at MR Bangladesh, will present, and Professor Ramanoj Mukherjee, who is Professor of Surgery at Arjigarh Medical College, will moderate this session. Abhishek, you can share your screen and present, and then wait for discussion. Share your screen.
Okay, sir. Sir, myself, Dr. Abhishek Tiwari, DNB first year resident, DNB surgery resident first year at the MR Bangur Hospital. I'm here to present a journal club on the topic of a randomized trial of low pressure 8 to 10 mmHg versus standard pressure 13 to 15 mmHg in pneumoperitoneum in laparoscopic cholecystectomy. This study was done by Tushar More, Deepak Falgune, and Shashank Shah. About the journal, editor-in-chief of Indian Journal of Surgery is Sandeep Kumar, country India. Online ISSN number is 0973 9793 and impact factor is 0.656, frequency bi-monthly. Introduction. More than 1 lakh laparoscopic cholecystectomy performed every year in India. Reduce pain, faster return to normal activities, and reduce risk of surgical site infection with a laparoscopic approach compared to the open operation. The aim of the present randomized controlled study was to compare the effect of low pressure versus standard pressure pneumoperitoneum in patient undergoing laparoscopic cholecystectomy. Why we need to do this? Because in pneumoperitoneum, adverse effects such as decreased pulmonary compliance, altered blood gas parameters, decreased stroke volume and cardiac output, raised liver enzymes and liver dysfunction, and increased abdominal venous pressures are seen with the pneumoperitoneum created in the laparoscopic cholecystectomy. Aim. Compare the effect of low pressure versus standard pressure in pneumoperitoneum in patient undergoing laparoscopic cholecystectomy. Study design, the type of study was single blind randomized study. The study was done in the Pune Hospital Research Center. The time of the study was 11th August 2020, and the total number of sample size was 100. Criteria of inclusion was the patient age was between 18 to 70 years, and the ASC grade, American Society of Anesthesiologists grade was grade 1 and grade 2. Criteria of exclusion was the body mass index was more than 30 kilogram per meter square, more than 30 kg per meter square, and if there is any coagulopathy, complicated gallbladder diseases like cholangitis, empyema, mucocele, gallstone ileus, biliary perforation causing biliary peritonitis, pericholecystic abscess, patient having pancreatitis, a history of ERCP and stent in situ, known shoulder disease, coagulopathy, a history of multiple abdominal surgeries. The primary outcome of the study was the incidence and severity of post-operative shoulder tip pain, and secondary outcome was incidence and severity of abdominal pain. Statistical analysis. The comparison of quantitative variables and qualitative variables between the group was done using the unpaired student t-test and the chi-square test or Fisher-Exact test respectively. Data collected were entered in Excel 2007, and analysis of data was done using statistical package for social sciences for Windows. Total number of patient eligible for the study was 120. excluded were 17, 3 were excluded due to the empyema of the gallbladder. 5 with the history of ERCP, 9 with the history of multiple abdominal surgeries. They were randomized by a processor randomization. A total number of low pressure samples as 52 were given low pressure, and 51 were given standard pressure. On follow up, because one pressure was on low pressure converted into open, so that's why the study was only done in 50 low pressure, and also in the follow up of standard pressure, one was converted to the open surgery. So that's why analysis were done on only 50 persons. As we can see from this table, that post-operative shoulder tip pain incidence at the 2 hour at the group A, which was low pressure group, at the present was shoulder tip was present only in the six peoples, and in the group B, which was the standard pressure, is 20. So we can see that this p value, the significant value was 0.001. So that's, we can see that the at low pressure value there is a decrease in the post-operative shoulder tip pain, and in the we can see the 48 hours the in group A, which was low pressure group, the incidence of post-operative shoulder tip pain was 0, and in the group B was 7. And the significant the p-value for the significant of the study was 0.012, which was showing that the group the incident of post-operative shoulder tip pain was low in the low pressure, low in the low pressure group. Incidence of post-operative abdominal pain at the 2 hour, the group A, which was low pressure group, at the 2 hour the patient present with the post-operative abdominal pain was 50, and group B, it's also 50. The p-value for this, so 0.999. So this shows that there's no much difference in the much difference in the low pressure and standard pressure group. So mostly the incident is same in the group low pressure group and standard pressure group. At the 8 hour, it's also 50, and group B it's 50, and at 24 hours it's group A it's 40, and group B it was 46. Where the p-value for this, the 0.148, which was significant. So in the 48 hours, it was 48 hours, the group A, which was low pressure group, the patient with the post-operative abdominal pain is 28, and in group B is 40. The p-value was 0.018, which was significant. So the post-operative abdominal pain after 48 hours in low group A was little bit less compared to the standard pressure group. Severity of post-operative shoulder tip pain. In the group A, which was low pressure group A, we have analyzed by visual analog scale. We explain to the patient and how to do the mark, and we have given a scale. On the basis we get the severity of post-operative shoulder tip pain. And the no pain was in group A after the 2 hours was 44, and in group B 30. Mild pain is in two people, and in the group B was 6. Moderate pain in the group A was 2, and in the group B was 5. Severe pain is in the group A is 2, and in the group B is 9. And the p-value which was given is 0.0015. So it shows the significance that group the severity of post-operative shoulder tip pain was less in group A as compared to group B. At the 48 hours, the no pain in the group A was 50, and in group B was 43. Mild pain is 0, moderate pain is 0, as compared to both groups are having same. The p-value for this is 0.012. And the severity of post-operative abdominal pain. At severity of post-operative after 2 hours, at the group A, Group A having 0 pain, and the group B is also having 0 pain. Mild pain is 27, and group B was 25. Moderate pain is 20, and in group B it's 21. The p-value is 0.885, which shows that there is no difference between group A and group B. After the 8 hours, no pain is both group B. A and group B is more or less is same, and the p-value for this is 0.858, which shows this there is no difference between group A and group B, which is low and higher standard pressure group. And at the 48 hours, and the no pain in group A was 22, and in the group B was 10. Mild pain is in 20%, 20 peoples, and in group B only in the 10 peoples. Moderate pain is in 8, and group B is having pain is 30. Severe pain, having none of the persons are having severe pain. So p-value was 0.001. So it shows that the study is significant, and severity post-operative abdominal pain after the 48 hours in group A low pressure, and in group B standard pressure. Group A is a little bit lower after the 48 hours. The study shows that the incidence and severity of post-operative shoulder tip pain and abdominal pain was significantly lower in the low pressure pneumoperitoneum group as compared to the standard pressure pneumoperitoneum group. As we can see from tables, the lower incidence and severity of post-operative shoulder tip pain and abdominal pain in the low pressure group may be because of decreased stretching of the intra-abdominal cavity and diaphragm and decreased pressure over the viscera. The study conducted in Haryana, India observed that both the intensity and frequency of post-operative shoulder tip pain and post-operative abdominal pain were lower in the low pressure group. A study also conducted in the western Uttar Pradesh, India reported that the low pressure group had significantly less pain. A study conducted in the Egypt reported that a significant difference was observed in the prevalence of pain at different pressure. Study limitation. The nature of pain studies was the subjective, which makes its evaluation vulnerable to the bias. Only the patient falling in the ASA grade 1 and grade 2 were included. The duration of surgery, post-operative hemodynamic parameters, complication, and post-operative hospital stay were not compared. The study was conducted on a limited patient population of 100 only. Conclusion: the incidence and severity of post-operative shoulder tip pain at 2 hours, 8 hours, and 24 hours and 48 hours significantly higher in group B, which was standard pressure pneumoperitoneum, that is 13 to 15 mmHg, as compared to group A, which was low pressure pneumoperitoneum, 8 to 10 mmHg. The severity of post-operative abdominal pain at 24 hours and 48 hours was significantly higher in group B as compared to group A. The incidence of post-operatively abdominal pain was significantly higher in group B as compared to group B as compared to group A. Thank you, sir.
Okay.
Hello.
Yes, Dr. Ramanaj.
Very good morning, Abhishek. This has been a good presentation, good attempt on your part. A few things when you start the journal club, sir. Number one is that whenever you make an academic presentation, please try to keep the slides in white and black, because you see, it becomes easier for everyone to see, and then it becomes an easy job for everyone to appreciate. Okay, now can you go back to the first slide, please? Right. Now, you have said about randomized trial of pressure control versus standard pneumoperitoneum in a laparoscopic cholecystectomy. I think the name suggests that this is a type of a randomized trial. Okay. Now, in a case of a randomized trial, can you tell me when is a randomized trial done?
So when we are testing any drugs, we are giving them a placebo and know the effect of the drug. We give a drug and give some patient a placebo, and we can study the effect of the drug and the side effect of the drug by comparing with the placebo and the drug.
Okay, so in a nutshell, you want to do a randomized trial when you like to compare two arms of a treatment.
Yes.
So like as you have done in this case, you have compared two types of pneumoperitoneum used for the same operation, a laparoscopic cholecystectomy. So this is the best way to know the effectiveness of a treatment, right?
Yes.
Now the next question is, what is the type of the bias which is avoided while you do a randomized trial? Or that means, what is the advantage of doing a randomized trial over a non-randomized study or a trial? This is something called as a selection bias.
Yes, sir. Selection
That
bias.
means selection bias is one where if you take non-randomized, like say in this study, now can you tell me how did the authors go for randomized, or how did the authors, we'll go to the material methods later again, but in this case, as you can very well see, that the authors have tried initially from the point one to say that we are dividing the two groups in a randomization, so that we will try to avoid something called as a selection bias. So this is a very, very important comment that they have made. Okay, now the authors and the direction that you have seen are all done. Can you go to the next slide, please? Okay, right. And you have now written a few words like impact factor, which comes in your examinations nowadays as question. What is an impact factor, Dr. Abhishek?
Impact factor is the how many times it's quoted in another studies or in another journal, how many times it is used.
So that is called as a citation factor.
Citation factor.
Okay, so
Yes,
that
sir.
means the number of the times the journal articles are quoted over 1 year or 2 year, depends upon what kind of indexing you are using and who is doing the indexing. But usually the impact factor is in a consort of journals or in a cohort of journals, how many times the journal article is quoted, right? So the next point of it is that after we have talked about that, this comes from the Indian Journal of Surgery. Now go to the introduction. What is the, or in a simple way, what is the format that any scientific literature like this has been adherent to? Or say you are going to write your thesis paper as a publication. What is the project or what is the methodology that these people have used to complete the write-up in any scientific paper like they have done? Abhishek, this pattern that you have seen is called as the IMRAD format. IMRAD. IMRAD stands for Introduction, Research Methodology, Analysis. Okay. So methodology is results, analysis, and discussion. IMRAD. Now, so come back to the introduction now. Introduction should state something called as a research question. What is the research question in your study?
So the low pressure, know the effect of the low pressure versus standard pressure in the pneumoperitoneum in the laparoscopic cholecystectomy.
Okay, so that means can you go to the slide where you have shown that? Right. So now something that you called as an aim. Okay, right. But aims and objectives are usually presented during when you write a protocol. When you are writing a publication, you do not usually present an aim. In the introduction part, you usually will go on writing the introduction, which will contain a very clear statement about what is the research question. And in the methodology, you may or may not mention the null hypothesis, that my proposal is this. Can you tell me in this one, so if this is your research question and if this is your aim, what is the primary objective and what is the secondary objective in this project?
So primary objective is, sir, the incidence of shoulder tip pain and the post-operative shoulder tip pain, and this primary objective, and the secondary objective is the known the incidence of the post-operative incidence and severity of the post-operative abdominal pain.
Okay, so it would have been better if you have written all of these, but
Yes, sir.
still it is good enough. Now, come to the, so if this is the introduction, what is the background on which you are working on this, or why is it important to study this research objective?
Sir, because because the standard pressure pneumoperitoneum, we know the adverse effect of the standard pressure, the causing the adverse effect in the pneumoperitoneum, adverse such as decreased, increased liver enzymes, increased pressure over viscera. That's why we need to do a low pressure. We create a low pressure.
Okay, so that means they are trying to see whether pneumoperitoneum has any adverse effect, and that is a very well-known fact. And so they are trying to see whether low pressure pneumoperitoneum is as equally effective as a normal pressure or say high pressure pneumoperitoneum. I mean, this is just a side question, because as they are deviating from the principle, do you know from your experience what is the usual pressure that you have seen to be kept during a laparoscopic cholecystectomy?
So, sir, 15 mmHg, sir.
15 is a very high pressure, sir. Sir, we usually keep our threshold at 12, maybe maximum 14. Usually it hovers around 10 to 12 millimeters of mercury is intra-abdominal pressure. More than 15 is basically the grade 1 of intra-abdominal hypertension will start now. So you will try to keep it below 15, particularly in patients who are having normal cardiorespiratory status. If the cardiorespiratory status is poor, then our anesthesiologists will usually prefer something not above 10. Okay, but that is what is standard. Now see, when you are presenting a journal article, now and you are critically understanding the journal article, that you are like, you have done a very brilliant presentation like this. So it is always good that in the discussion, when we again come back to the discussion, we will again answer that. Say for example, have you read any recommendations about any pressure that should be kept during lap pulley from any bodies or any guidelines? Have you heard about this? I have not.
No.
So please go through something called a SAGES guideline, SAGES. Okay. Many Indian organizations, even they have their very good guidelines. You are requested to please look into those guidelines around what is the pressure that they have recommended. So because these people have deviated from what is usually the practice. Now, so when it is a practice that they are trying to deviate, so now come to, so the introduction part is clear, that they are trying to propose the research question that whether low pressure is as equally effective, or what are the problems that they are trying to avoid. So that is their main question. Now come to the methods. Now in this method, they took a pool of patients. How did they include the patients?
Sir, patient undergoing laparoscopic cholecystectomy aged between 18 to 70 years and ASA grade 1 and 2.
Okay, that's a good one. Now, in this point, just one query to ask about. In this methodology, the flow chart that you have made,
yes,
can you show that flow chart once again?
Yes, sir.
Okay. Now, in this flow chart, there has been an important word called as a consort statement. Do you know the meaning of the word consort statement? CONSORT?
Yes.
What is that, Ravishek? Well, you see, if you go to the internet and search something called as a consort or randomized trials, a brilliant page opens up that is called as consort. It is absolutely free. Now, anyone who does a randomized trial, anyone, so everyone who is listening to this, please remember that for your thesis also, if you are using the word randomized, you must must always use an checklist called as consort checklist, which follows a pattern. There is a 23-point checklist, and you must satisfy all the points, like the name must include randomized trials, etc. And that includes that, and that is a way of going around in a randomized trial. If you go to the methodology that you have shown to us,
Yes.
that methodology is exactly reminiscent of what the consort is going to tell you about in this way. Okay. So this is for all to understand that if you are planning to do your thesis, particularly comparing the two arms, even if you are not doing a non-randomized study, still this one gives you a beautiful way that you can think into that. Now, to begin with, you have patients who are waiting for a laparoscopic cholecystectomy. Now, who were included and who were opted out from the study?
Sir, any patient in the criteria?
Come to the inclusion and exclusion criteria.
Criteria for inclusion was patient age between 80 to 70 years, and the ASA grade was 1 and 2.
Good. And so what was the exclusion criteria?
So the anticoagulopathy and the aged, the BMI was more than 30 kilogram meter square, and the patient with complicated gallbladder diseases like cholangitis, empyema, mucocele, history of gallbladder ileus, perforation causing biliary peritonitis.
Right, I understand that. So that means they have tried to exclude these diseases. Okay. Why do you think they have tried to exclude these diseases?
Because sir, they will cause bias. They will causing a bias because we are having
they are something called as confounders. Because your endpoint, say for example, see how good that these study people have tried to think about shoulder pain. Now, so
yes,
if they think about shoulder pains, if the patient already has a shoulder pain before the operation, so that will be a confounding effect. Like the patient may have had an empyema, which is a pus collection in a gallbladder. So that is going to produce again maybe a post-operative peritonitis. So they have tried to remove all the confounders. So that's a good way of understanding this project, and that's a good paper publication that you have taken for your work. Good. So now come to, so you have talked about consort statement you have taken, and then now come to the list now. Yes, this one, the flow diagram, please.
Yes.
Right. Yes. So now you have said that, so low pressure pneumoperitoneum and this, and how is the way of randomization that they have attained?
By the sir, a processor called a randomizer, by which we allot a random number to the persons, so that there we can allow we can remove the selection bias, because we don't know the which person may get which number, and they fall in the low pressure or they fall in the standard pressure.
Right. Now it is very interesting that you see that in that follow arm, you have one patient who was converted to a standard procedure. I do not think whether I can mark it for you or not. Okay, but I think yes. I think this part converted to a standard procedure. Now, so you see, this is very interesting because this patient was converted to a standard procedure. Which arm did this patient go? Did you understand the question?
Yes, sir.
So did this patient go in the standard lap chole, or did this patient come in the low pressure lap chole? So this has been a tough question. So again, we'll come back to that, because when you analyze, you see they have made it 50-50.
Yes,
well, if you think about it, that one patient should not have been, either should have been in the standard lap chole, that would have made it 51, or if it had been in this group, it would have been 51. So there is a problem regarding this patient. And when you are talking about this type of patients, what is the additional methodology that you should have done? That is something that they have not done in this project. That is something called as intention to treat analysis, ITT. Okay, so that is another thing that statisticians are expected to do. That if this patient had not crossed over, then what would have been the effective outcome? But in this one, there is only one patient, but still in the methodology and the research, they should have stated that. Now come to the results now. So this is a 2x2 table. Okay.
Yes,
So when you talk about the 2x2 table now, as you can see in this one, what are the things that have been different in the two groups? What are the things that are not different in the two groups?
The different in the two groups is the low pressure group. One group is having low pressure, and the group B is
No, I
having.
understand that. What is the thing that is better, or what is the thing that in the low pressure group, or what are the objectives that you have seen in, say, post-operative shoulder pain? Is it different in the two groups? Yes or no?
Yes, sir. Different.
Okay. At which hour is it different?
So at the 2 hours, it is different because the p-value which is showing
Right.
point.
So the only significant p-value is at the 2 hours. So that means the low pressure group has lower incidence of post-operative pain at 2 hours. So Abhishek, in the next time when you are writing or presenting a journal club, it is a request that whatever is your conclusion from this table, the audience who is listening to this has to have this very clearly mentioned, that at 2 hours, as you can see in this project, only this is the one which is different, whereas the others are not different.
Yes.
So it is a just single line take home that you should write at the bottom of the slide. The next point.
Dr. Raman, at
Yes.
this point, I think we have not, the author has not given us the idea about the duration of surgery. That is also important.
Sir, about sir,
duration of surgery and the analgesics used. It should be the
Right.
same analgesics for all the patients.
Absolutely.
Because you see, the duration of surgery is an effect which causes more absorption of carbon dioxide and the stretching will be more prolonged period. So there should have been some comparison between the duration of surgery and the pain.
Absolutely, sir. Absolutely. Sir, very well point mentioned about this. Right. Okay, we should go to the next slide kindly.
Yes.
Okay, in the post-operative abdominal pain, as sir has said, a very, very valid and a very important point, that what has been the duration of surgery, number one. Number two, what has been the analgesic usage, whether the same drugs were used, in what dosage does need to be analyzed. Right.
Yes.
In the post-operative abdominal pain, any significant findings?
Sir, at the 48 hours, it is only showing less number, more or bit
but
less.
The p-value is not significant, isn't it?
P-value is not that much significant.
Okay, so they had early post-operative pain, shoulder tip pain, and post-operative abdominal pain. Any other points or any other results that they have tried to analyze?
They had analyzed severity of post-operative post-operative shoulder tip pain and severity post-operative abdominal pain only.
Okay, so these are the only two objectives that they have attended, na? Right. Okay. Now come to the discussion about what are the points that they wanted to elaborate. Okay, so they have said that the post-operative shoulder tip pain and abdominal pain were significantly lower. Is it really significantly lower in the abdominal pain? Because the p-value was not significant.
Yes, sir.
So see, this is one of the caveats or one of the drawbacks in this article that you should know how to point out.
Okay.
Because whenever you are reading the article, that means that you need to critically analyze these points. Shoulder tip pain, I understand, but abdominal pain, well, I'm not agreeing to this. So this is the first point of concern. Number two is that, so this is done and they have tried to propose something of an answer. What is the next point?
So they have lower incidence and severity. They have tried
that is in the discussion. Any other data that they have commented which looks like the contemporary data?
No, sir.
No, no.
No.
Good. So now tell me, what are the drawbacks? Hello.
Hello.
Yes, sir. Okay. Now, Abhishek, in this study, what are the drawbacks that you can find in analysis of this whole paper? This has been my last topic of discussion now.
Yes, sir. Sorry, sir.
What is the caveats or what are the flaws, or if you want to critically analyze, what are the problems that you think, or what are the points that could have been improved in this methodology of study?
So they had taken a large sample so that we could get a better result.
So, right. So that means the sample size was less, only 100 patients. Okay, number one. Number two.
Number two, they also should have taken into consideration the drugs they have using, the hospital stay of the patient, where the duration of the patient staying in the hospitals after the
So
operations.
number one is their sample size. Number two is something called confounders.
Is a confounders.
Like as Saas has said, like which drug was used, what is the dose, and what is the duration. Third is if you are adding that there could have been additional points of evaluation. Fourth
yes.
is this is a single blind study. That means only the patients were not knowing which arm they were on.
Yes, sir.
The evaluator who was assessing the abdominal pain, maybe the surgeon or the anesthesia, they knew which arm the patient was. Maybe then that would have represented with a selection bias, or in which that, say, the patients with a low pressure, the observer may have felt that they had a low. So it would have been a double blind with the independent observer would have been a more better way to do that project, right?
Yes.
So I think that this is a short paper. There are few again say caveats that needs to be discussed, but yes, for a small thesis work that you can do for your exams, this is just an eye opener around how to start with working on simple topics like this. The project was in a nutshell a good one, but definitely has its own drawbacks, and the sample size was less. It should have been a double blind study, which would have made it more better for the criticism in this project. Okay, so that is from my answer.
Thank you, Raman. We would have discussion, but you have said.
Okay.
Okay, sir. Hello.
Okay then. Thank you then, sir. Thank you, everyone.
Thank you, sir.
Thank you, sir.